So we just finished talking about the differences between RN, LVN, and CNA. But when I was talking about medications, how a CNA can only do a topical ointment such as Balmex or A&D ointment, I did want to clarify that there are some CNAs that work in an assisted living residence or assisted living homes, and they can actually take a course called a med tech course and assist patients in being able to take their own medications. But in a nursing home or a hospital, it is never allowed. The only thing you are allowed to do is the topical over the counter ointments. Now, nursing patterns are something, there's actually, your book describes multiple different nursing patterns, but I just wanted to talk about the more common ones. And functional nursing is what we see a lot of times in the nursing home. In functional nursing, the CNAs do those activities of daily living, the bathing, the cleaning, the helping them feed, walking, ambulating. The LVN will pass medications, do treatments, and the RN will do IVs, IV medications. They'll do assessments of new admission patients. And then if there's any type of medication or any type of treatment that an LVN shouldn't be doing, then the RN would take over for it. Team nursing is where the RN, LVN, and CNA, they work as a team, which truthfully in functional nursing, it is very similar to team nursing. And then it'll just be delegated out who's going to be doing what. Where in functional nursing, you have more specific roles of what you would be doing. And then there's primary nursing. And hospitals a lot of times do primary nursing. And what primary nursing is as an RN, for instance, doing primary nursing, I would have less patients than what I might have in a nursing home doing functional or doing team nursing, but I will do everything for that patient. I will do their activities of daily living, their medications, their assessments, their treatments. I take care of everything. So there's different styles of nursing, and depending on where you work is the type of nursing pattern that they may be doing. Now, as far as who pays for healthcare is exceptionally expensive. And I know it's always a hot topic every time there's a presidential election. Of healthcare is always addressed because it is an exceptionally expensive thing. Insurances are expensive, healthcare is expensive, and they're always looking at trying to redirect it, remanage it to best utilize our resources. So paying for healthcare, a lot of people will have private insurance. So for instance, you don't work somewhere, you're wanting to buy insurance for yourself, you can buy private insurance. Group insurances are provided by organizations. Now, the nice thing about nursing is, whether as a CNA, an LVN, or an RN, hospitals, nursing homes, assisted living residents, they almost all provide insurance for you, a type of group insurance. Now, group insurance can be HMOs or PPOs. HMOs are health maintenance organizations, and health maintenance organizations, what happens is you will choose a primary physician, and that primary physician will determine what tests you need, if you need to see a specialist, and it will dictate who you can see. PPOs, preferred provider organizations, you have a little bit more flexibility and a little bit more choice, but of course they're more expensive. You can choose the doctor you choose to go to. If you want to go see a specialist, you can choose to go see a specialist. You don't have to be referred. Costs for the insurance is much higher, and a lot of times the co-pays are higher as well. The Patient Protection and Affordable Care Act, known as Obamacare, was a healthcare exchange through government bodies. It's altered and changed quite a bit over the years. Every time we have a new president, it'll probably continue to keep changing. And then we have Medicare, federal insurance, and Medicare is for 65 and older. And it is to provide Medicare for our seniors, for our elderly. And so it is something that people pay into with their jobs. They pay into the Medicare insurance program. That helps take care of the seniors that we have now. And then hopefully the younger people, once they're putting into Medicare, then that would cover, as you get older. So it's kind of an ongoing thing. There's been talk about Medicare is not doing well and financially, and that they're afraid that the Medicare benefits are going to eventually go away. Of course, they've been telling us that for probably the last 20 years that there wasn't going to be Medicare, and there still is, but they have changed it a lot. There's a lot more restrictions on it. And then there's Medicaid, and Medicaid is a federally funded program. Medicaid is for patients that have disabilities, that are on permanent disability or low income status, and it is so they can get basic medical care. Now, standards and survey processes happen in nursing homes and they happen in hospitals. And so in hospitals, there is what we call the Joint Commission, or there is another organization called DNV, not an N, not an M. And they are organizations, so a hospital can either become a Joint Commission approved hospital or a DNV approved hospital. And these companies come in and they basically go over the hospital from head to toe. It's policies, it's procedures. They talk to patients, they talk to nurses, they watch nursing processes, they look at charting, and they want to make sure that hospitals are doing what they're supposed to be doing and that care is appropriate. So hospitals are usually evaluated by either the Joint Commission or DNV, and then in addition, California Department of Public Health comes in and evaluates them as well. Hospitals are usually evaluated anywhere between 18 months and 3 years. So at 18 months, they can come in and get evaluated again, or it may be 3 years before somebody shows up to evaluate them. It's no longer announced. It used to be, we're going to come and evaluate you next month. And so hospitals could basically beef up its standards, beef up its staff, and try to improve everything right before they came. Now it's just they show up. And so you basically always have to make sure you're doing what you're supposed to do. Now, nursing homes, they are not regulated by Joint Commission or DNV, but they are regulated by the California Department of Public Health. And California Department of Public Health comes and evaluates nursing homes every single year. And so nursing homes, it's a very, very stressful time when they come, and they're there for a week, and they basically go through every aspect of that facility and determine if they feel things need to be improved upon or if they're doing things correctly. It is a stressful time for the facility, and if we are there as students, we may or may not be asked to leave. I was up at Ojai Continuing Care Center doing my clinical rotation with my students one time when the state showed up, and the state was they were, the facility said, hey, you guys are helping us. You're doing a great job. You guys can stay. Other times I've been at other facilities and the state shows up and they're like, oh, please just leave. Please just take your students. And so if that happens, then we go back to the college. And we'll practice on some things in the skills lab. It's just, you have to remember, this is so, to have somebody watching everything you do and going over every process that you have is stressful. And then to have students that are there asking questions and doing things as well, it can just put an extra layer of stress on them. So we may or may not be asked to leave if the state shows up. As far as our role in meeting standards at a facility is, we are supposed to always provide good quality care. Now, we should be doing that all the time for every patient. I mean, people don't go into nursing because they want to hurt someone. You go into nursing because you want to help. You want to make somebody's life better. And so our job is to always provide good quality care and to help protect the person's rights. And we're going to be talking a lot about patient rights and residents' rights, but this is one of the major things that they're looking for when the state comes, when CDPH comes. They observe their CNAs to see, are they asking permission? Do they knock before they go in? Into the patient's room? Do they ask permission before they give care? Do they give the patient choices? Are we still letting them choose what they want to do and when they want to do things? So that's always a really big thing that they're looking for. We also want to provide for the person's safety and our safety. We want to make sure we're keeping our patients as safe as we possibly can, and that we're doing it in a manner that we aren't going to get hurt as well. We want to help keep the agency clean And they do have housekeeping staff, but you know what? It's our responsibility too to clean up after ourselves, to help clean up after our residents when we're taking care of them, and to make sure that we're keeping things as clean as we can, because that's going to help decrease infections. We want to act professional at all times, and we're going to talk in more detail a little bit later about, professionalism and using good work ethics. And we're going to talk about that more. Ethics are things that you should and shouldn't be doing. They're moral choices that you make for yourself. And we always want to make sure we follow policies and procedures of the facility. If a facility has a policy and we're not following it and something happens to that patient, we can get in a lot of trouble legally and just, ethically as well. So, for instance, in our program, one of the things that we have told you, or that we went over in your syllabus and your handbook, is that you will follow the policy regarding gait belts. A gait belt, gait, G-A-I-T, like walking, ambulating gait, a gait belt is used for patients that are potential fall risks, and it helps give us something to hold on to. It helps us control their movements a little bit better, and it may not necessarily keep them from falling, but it should help with it. And if they do start to fall, we can actually control it so they don't get hurt in the process. So most facilities actually have a policy that will say, if the patient is a fall risk, you will use a gait belt. And when we go into the nursing homes, you're going to see sometimes the CNAs don't use those gait belts because they don't want to take the time to do it. If you use a gait belt correctly and you get used to using it, it takes 5 whole seconds to put it on, maybe 10 at most. And so these CNAs, if they go and they move that patient and they get that patient up without that gait belt, when it's been documented that they're a fall risk, and that patient falls and they get hurt, it is going to be a huge legal issue, and it is going to be something that it's showing that we are not following our policies and procedures. We are not doing what's called standards of care, and it is ethically wrong. And it is something that can get us in a lot of trouble and can harm the patient. And if at the facility, when the state is there and they're going around looking, if they watch you get a patient up who's a fall risk and you're not putting a gait belt on, and that gait belt is per policy something you're going to use, that facility is going to get dinged. They're going to get a deficiency. And if they get too many deficiencies, they can actually get shut down. So it's a really big thing. You need to always follow your policies and procedures. They're there to help keep your patients as safe as they possibly can. So we're going to end here, and we'll do a little test on what just like a little knowledge-based test to see what we've learned so far.